Thank you very much, Ethan, for that introduction, and I'm delighted to be here to talk about this important topic. Just a word on disclosures. At Memorial Sloan Kettering, we developed a panel of 4 kallikrein markers related to PSA, which has recently been licensed to a company called OPKO to commercially develop this, and I'm on their scientific advisory board. So with that in mind, should we still screen men for prostate cancer with PSA? Is it really conceivable that we would stop testing men for PSA as a way of diagnosing prostate cancer? I don't think so. I think I grew up in the era when there was no PSA, when men presented with advanced disease and difficult to cure cancers, and I don't think we're really going to go back to that era. But I think we can stop using PSA the way we've been using it and use it in a much smarter way to lessen the harms and retain the benefit and good things about PSA testing. So my disclosures again, and Ethan mentioned the U.S. Preventative Service Task Force, but just to review their grade D recommendation, they recommend against screening for prostate cancer with PSA at all, arguing that there's moderate or high certainty that there is no benefit or that the harms outweigh the benefit, and they discourage the use of PSA screening. What's wrong with the way we've been using screening for detecting prostate cancer, certainly in the United States? I do think on reflection it's been harmful, and I think the criticism from the U.S. Preventive Service Task Force was appropriate. There's been too much screening of elderly men with a short life expectancy. The criteria for biopsy have been too liberal, resulting in many false positive tests. Low risk, low stage, low grade cancers have been treated aggressively, causing more harm than good. I think the treatment of high risk cancers, potentially lethal cancers, has too often been inadequate. And treatment has largely been administered by low volume providers so that there are higher risk of side effects of the treatments and lower chance of cure and greater risk of harms. This is the data published in the JCO 2 years ago, looking at the prevalence of PSA testing by age in the year 2000 and the year 2005. You can see very few men below age 50 are being tested, but testing levels are extraordinarily high in elderly men over the age of 70. Some 40 to 50% of men in the 70 to 75 and the late 70s age group, even 40% of men in their early 80s are being tested with PSA, and that is an inappropriate use of PSA testing. Several years ago, we published a paper in JAMA looking at a group of 1,000 men randomized on a diet to prevent colon polyps trial. None of these men had prostate cancer, and they were all carefully evaluated to rule out other cancers. But each year they gave a blood sample, so we had 1,000 blood samples over 5 years that we went back and analyzed using a variety of different cut points for an abnormal PSA. At a level of PSA at a level of 4, at a level of 2.5, the age-specific PSA levels are using percent free PSA for those with a PSA between 4 and 10. Over the course of the 5-year study, in these healthy men without prostate cancer, 37% of the men at some point in the 5 years had a PSA that crossed the threshold of abnormality. You can see that range from a high of 37% for a PSA threshold of 2.5 to a low of 15% using the free PSA. But if we simply followed those patients and did nothing and tested the blood again the next year, about 50% of the patients, the PSA level spontaneously returned to normal. No antibiotics, no intervention, just waiting a year and repeating the test. And when it returned to normal, it largely remained normal in roughly 80% of the men over time. So this gives some sense of the inherent variability of PSAs and the frequency of false positives that happen if men simply get tested annually over and over again. The Preventive Service Task Force pointed out the harms done by biopsy, and I think it's true. Prostate biopsy is not harmless. There is a hospitalization rate that ranges from 2 to 7% in the 30 days after biopsy. Sepsis occurs in somewhere between 4 and 13 or 14 men per 1,000 biopsies, bleeding in about 4 men per 1,000, and urinary obstruction in 2 to 8 men per 1,000. So there are consequences of biopsy. A transrectal ultrasound-guided biopsy even a transperineal template-guided biopsy is not harmless, and a decision to have a biopsy should be made seriously. The side effects of radical radiation or surgery for prostate cancer have been well documented. This is Marty Sanders' paper in the New England Journal of Medicine 5 years ago that showed that sexual function caused moderate or severe distress in 43% of men after surgery, 37% after external radiation, and 30% after brachytherapy. An independent interview with their partners confirmed this distress. Urinary function caused moderate or severe distress in 7% of patients a year after surgery, 11% after radiation, and 18% after brachytherapy. And GI symptoms caused the same level of distress in 9% of patients regardless of the technique of radiotherapy. So treatment of prostate cancer carries serious risk and serious side effects. Overdetection, I think, was correctly pointed out as a major problem. Studies have estimated that somewhere between 10 and 56% of patients diagnosed with prostate cancer in this country in the last 10 years have had a cancer that would never have come to the attention of the patient, caused symptoms, or caused premature death, and that the lead time for PSA-detected cancers was between 5 and 12 years. Peter Carroll, in his studies of practice patterns across the United States, has correctly pointed out that between 1990 and 2007, few men with low-risk prostate cancer have actually been assigned to active surveillance and have been watched conservatively. Only less than 10% of men diagnosed with prostate cancer during that era would accept or were recommended to have active surveillance. And this was a major problem that I faced. Counseling men in that period to watch their cancer once it was diagnosed was very difficult to do. You'd spend quite a bit of time in the clinic with the patient, with their wife, the wife often in tears saying, "You're going to let my husband die. We don't care what the side effects are, just get rid of the cancer." Fortunately, that attitude has changed. One of the benefits of the publication of the PIVOT trial and the Preventive Services Task Force recommendation is that the public, men who are diagnosed with prostate cancer, are much more aware of the controversy and leery about rushing into radical therapy. The other concern from Peter Carroll's study is that high-risk patients who have the most deadly, potentially lethal cancers are too often treated conservatively with androgen deprivation therapy alone in nearly half of the patients. So we're over-treating low-risk patients and often under-treating high-risk patients. But I think there are serious flaws in the U.S. Preventative Service Task Force recommendation. The European trial, which was the most successful large-scale randomized trial of PSA testing, had not reached its primary endpoint when the analysis was done. There was inappropriate inclusion of very different trials in the meta-analysis. There was a lack of appreciation for the very strong relationship between PSA and prostate cancer mortality and the long time between a PSA change and the death of a patient from prostate cancer. The overall mortality was criticized as not being affected by PSA screening, but that's not really an appropriate endpoint for a screening trial. And the mortality of surgery was exaggerated as 0.5%. That came from Medicare data for patients treated in the 90s and is not representative of the mortality across the board in this country, certainly. Let's look at the two large screening trials that have been published. The PLCO trial in the United States showed no benefit of screening. There was no reduction in prostate cancer mortality, but the European trials found a reduction of 20% in the risk of dying from prostate cancer over a 9-year period, but their concern was that it came at a very high cost. 1,400 men would need to be screened and 48 cancers diagnosed to prevent 1 death from prostate cancer. So a high price to pay. Many men screened, many men diagnosed, and many treated for a small benefit. But in the Gothenburg arm of the European trial, which started independently as a randomized trial in Sweden and included nearly 20,000 men, truly randomized to either receive PSA testing every 2 years or no screening, which was the standard of care in Scandinavia at that time, has longer-term follow-up out to 14 years and showed that in the first 10 years, there's little apparent reduction in prostate cancer mortality from PSA screening, but as these men were followed longer, the difference between the unscreened group and the screened group became larger and larger. So in this 14-year study, the reduction and the risk of dying from prostate cancer was 44% in all men. It was 56% in men who were actually screened. Now the number needed to screen to prevent one death was 293, not 1,400, and the number needed to diagnose was 12, and not all 12 of those were treated. Those with low-risk cancers were placed on watchful waiting, and so reduction in treatment harm was appropriate in that trial. We've looked at large population-based studies in Sweden and at the relationship between a man's PSA level at age 60 and his lifetime risk of developing clinical prostate cancer or dying of prostate cancer. This is the risk of dying of prostate cancer by your PSA at age 60. The median PSA for these men at age 60 was 1. Men below 1 had almost no risk of dying of prostate cancer over the next 25 years. But the higher the PSA at age 60, the greater the risk. This allows us not only to risk adjust screening for prostate cancer, but points to the extraordinarily powerful relationship between a serum PSA level in a man at middle age and his risk of ever developing a clinically significant prostate cancer or dying of the disease. But it takes a long time for this relationship to play out. More recently, and you'll hear more about this today, the New England Journal of Medicine published a quality of life analysis of men modeled as having PSA screening between age 55 and 69 and followed over their lifetime. And I won't go into the details of this trial because you'll hear more about it, but here when the effects of screening were carried out over a lifetime, one prostate cancer death could be prevented for 98 men screened, and 5 cancers would need to be detected or treated. And in that trial, 2 men of these 5 were placed on watchful waiting, 3 were treated, and that still a life was saved. So I think we see as we get better and better data that there is a very powerful effect between PSA testing and reduction in mortality from prostate cancer, and the cost-benefit ratio is much better than it was in the early analysis of the randomized trials. So how can we increase the benefits and reduce the risk of screening for prostate cancer? I think we can readjust screening by age and PSA levels to reduce the number of false positive tests. We can reduce false positive PSAs by the addition of new markers, the 4-kallikrein panel, which was developed at our institution, the Prostate Health Index, which includes -2 pro-PSA, which results in a more specific panel of kallikrein markers. The new urinary markers like PCA3 all can help reduce the indications for inappropriate biopsy. Active surveillance is becoming much more accepted and much more widely practiced in this country and others that will reduce the harms of unnecessary treatment. And if we can refer patients to high-volume physicians and centers, we can reduce the harms of treatment when it's necessary. Just taking a look at these data in specific, in 2010, we revised our guidelines based upon the long-term studies of PSA and outcomes with prostate cancer mortality, and recommend beginning screening at age 45 for men who are informed and understand the risk and benefits and want to be tested. For men in between 45 and 59, if the PSA is elevated above 3, consider biopsy. Between 1 and 3, return not every year, but every 2 to 4 years. And for men with a PSA under 1 at this age, come back in 5 years or at age 50 or 60, whichever comes first. Between 60 and 70, the same protocol, between 1 and 3 every 2 years. Under 1, no further screening. And for men 71 or more, no further screening. With this approach, you can identify those who really are at risk and avoid over-testing men in the elderly age group who are much more likely to have identified cancers that are not going to prove lethal. After all, PSA testing is the best way to understand what your risk of dying of prostate cancer is. It's far more powerful than knowing your family history or your ethnic background or any genotype testing we can do. There are a variety of new markers. You'll hear about some of those this morning, but the 4K panel and the PHI have both been shown in large studies to reduce the risk of unnecessary biopsies. For example, in the European screening trial of 740 men who were biopsied because their PSA was over 3, if we applied the algorithm of this 4-kallikrein panel of markers, we would have reduced unnecessary biopsies by 57%, missing only 3 poorly differentiated cancers out of the 740 patients, but reducing the detection of low-grade cancers much more actively. So a much more sensitive and specific screening trial. This panel has been thoroughly evaluated in a variety of different settings in men previously unscreened, prior screening, men who've had a previous negative biopsy, even unscreened men who've simply been followed to see what happens to them, and it performs much better than PSA alone in each of these, particularly for the detection of high-risk cancers. Active surveillance has been pursued widely and is now shown to be very safe. The risk of coming off active surveillance in 5 years is less than 20%. In 10 years, about a third of men have come off active surveillance, but 2/3 of the men are on. In Lori Klotz's study, the risk of dying of prostate cancer is very low. That's this yellow line, and the risk of dying of other causes is much higher. So this is a very safe strategy that's now being pursued much more actively. This is the number of men placed on active surveillance at our institutions. Now of about 1,000 men referred for surgery, 250 of them are placed on active surveillance every year. The same thing's seen in Great Britain, and I think around the world there's much greater understanding and appreciation for the importance of active surveillance, and men are much more willing to accept it. Population-based studies show that men with low-risk prostate cancer live just as long without treatment as they do with treatment. Men who have intermediate risk or high-risk cancers, however, are at much greater risk of dying than their cohorts without prostate cancer. We have the Swedish randomized trials showing that radical prostatectomy significantly reduces the risk of dying of prostate cancer or of developing metastases compared to watchful waiting. The reduction is 38% for prostate cancer death and 41% for metastatic disease. The PIVOT trial, I think very appropriately carried out in the United States, showed that overall there was no survival benefit to surgery versus watchful waiting, and no benefit in terms of prostate cancer specific mortality. But when we looked at subgroups in that trial, men with a PSA over 10 or men in the AUA high risk group, there was clearly a benefit of treatment on the order of magnitude of the European trial, substantiating that for many men with intermediate or high-risk prostate cancer, treatment can make a big difference. Overall, there was a reduction in metastatic rate for treated versus untreated patients in that trial, but specifically in the intermediate risk group, the hazard ratio for reduction of metastasis was 0.56. So if we look at the pattern of care in the United States over the last 25 years, PSA did result in a much greater increase in prostate cancer diagnosis, but it was already rising before that and has flattened off at a higher level since then. But most importantly, the mortality rate from prostate cancer on an age-adjusted basis peaked out in 1992 and over the last 20 years has dropped by 45%, a remarkable and significant reduction. And I think that much of that has been due to early detection of prostate cancer with PSA testing. I can't imagine a world where we wouldn't use PSA appropriately, and I think we can screen more effectively and continue to lower the mortality rate from prostate cancer while reducing the harms of overdetection and overtreatment by risk adjusting the frequency of testing depending upon the baseline PSA, reconfirming an apparent elevated level before recommending a biopsy, using new markers with greater specificity to reduce the false positive results, and expanding active surveillance for men whose cancers pose a low risk of metastases or premature death. Thank you very much.